Muy buenas tardes. Vamos a continuar con la sesión de hoy día en la mañana del módulo de tratamiento y prevención de los grandes síndromes obstétricos. Tenemos el gusto de estar nuevamente con el profesor Emmanuel Bujold. Y Emmanuel hoy día en la mañana nos dio una clase muy buena acerca de prevención del primer trimestre de los grandes síndromes obstétricos. Y ahora vamos a hablar acerca de las posibles intervenciones o posible tratamiento para prevenir estas patologías con el uso de aspirina. Emmanuel.
Thank you. The history of aspirin started several centuries before Christ. However, Bayer started producing aspirin only in 1887 and became one of the most popular drugs over the world. The history of aspirin in the prevention of preeclampsia started about 3 to 4 decades ago, when Goodlin reported a case of prevention of recurrent preeclampsia. The following year, there was a retrospective study which showed that women who were taking aspirin for other reasons during pregnancy were less likely to develop preeclampsia than the others. The reason for that difference was believed to be a differential inhibition of cyclooxygenase between platelet cyclooxygenase and vessel wall cyclooxygenase. The first randomized trial was published in 1985 by Prof and colleagues, who found that by taking 150 milligrams of aspirin daily, started around 12 weeks of gestation, was associated with significant reduction of preeclampsia, IUGR, and perinatal death. In the next 2 decades, several randomized trials were performed. Here is a list of the major ones. However, the initiation of aspirin in those trials was much later, most of them recruiting women at the time of the mid-trimester ultrasound, around 20 weeks. Moreover, they were using much lower dosage of aspirin. More than 50 randomized trials later, the results are contradictory, and there's a belief that aspirin has only a minimal effect for the prevention of preeclampsia. But could the late initiation of aspirin explain the negative results? Since transformation of uterine spiral arteries is mostly completed by 16 to 18 weeks. So our hypothesis was that low-dose aspirin started early in pregnancy can prevent a higher percentage of preeclampsia and IUGR than when started at mid-gestation. This is not a novel idea. Several expert and national societies reported that idea before. However, previous meta-analyses evaluated the effects of gestational age, but they compare studies that recruited women before 20 weeks to those who recruited women after 20 weeks. However, since most of the women were recruited around 20 weeks, they were comparing approximately the same population. So we decided to do the meta-analysis again. So we performed a systematic review and meta-analysis limited to studies comparing low-dose aspirin to placebo or no treatment. We used a similar search strategy and selection of articles than the Cochrane database used. And instead of comparing women who received treatment before and after 20 weeks, we stratified the studies by gestational age at initiation of aspirin before and after 16 weeks, when the transformation of uterine spiral arteries is believed to be completed. So out of more than 7,000 citations, we found 12 studies who recruited women before 16 weeks and 22 who recruited women after 16 weeks. And here are the results. So for the studies who recruited women before 16 weeks, we found a significant reduction in the rate of preeclampsia, while there was no effect when women were recruited and randomized after 16 weeks. So we found that starting low-dose aspirin in high-risk women before 16 weeks can reduce the rate of preeclampsia by about 50%. And we found about the same differences for UGR. And as you can note, there was a complete homogeneity between the studies. Looking at the number needed to treat, we found that approximately 9 women identified at higher risk for preeclampsia would need to be treated in order to prevent 1 case of preeclampsia, most likely a case of severe preeclampsia, and 1 case of a UGR. You can note that there was no increase in the rate of placental abruption. Following the publication of our meta-analyses, 2 other randomized trials were published. The first one from Bakhti and Veyman, who found a decrease in the rate of gestational age hypertension, preeclampsia, and HELP syndrome with low-dose aspirin started around 8 weeks. And the Predo trial that was presented in Melbourne 2 years ago, who recruited nulliparous women with bilateral notches on uterine artery Doppler who were given low-dose aspirin or placebo. While the differences were not significant, they most likely because of power issues, they found a decrease in the most severe disease. So we recently looked at the effect of severe preeclampsia and or preterm preeclampsia in another meta-analyses, adding those 2 studies, and we found that using low-dose aspirin early in pregnancy can decrease tremendously the rate of preterm preeclampsia and severe preeclampsia, but had no effect on the term and mild disease. It makes sense since, as I presented earlier, preterm and severe preeclampsia seems to be more related to defective placentation compared to the term and mild preeclampsia. So in conclusion, low-dose aspirin is effective in the prevention of preeclampsia, but most likely in prevention of severe preeclampsia and IUGR when started before 16 weeks. So what about the other great obstetrical syndromes? As I said earlier, it seems that they all are related to disorder of deep placentation. We looked at the effect of low-dose aspirin on the rate of preterm birth. While none of the studies were designed to evaluate the effect of aspirin on preterm birth, as I said earlier, it is possible that part of the preterm birth can be predicted with the same prediction model. Anyway, I'm sorry. We found that in those 4 cohort study, that women who received low-dose aspirin in early pregnancy were much less likely to deliver preterm compared to the controls. And in fact, we found a very low rate of preterm birth in those women. We're not sure. I believe that even if this result were very significant, I believe that this should be reevaluated in a bigger trial. And we're not sure how aspirin would work. Would it be only because of improvement of placentation or because of its anti-inflammatory effect? So anyway, so far this is the data that are available right now. Moreover, we thought about maybe since stillbirth a lot of stillbirths are related to defective placentation, that aspirin could be useful in the prevention of stillbirth. Right now, there's only one study available, and that study from Bakhti found that low-dose aspirin was associated with a decrease in perinatal death. But we're working on a meta-analysis right now, and hopefully we'll have a better result soon. So my conclusion number 2, low-dose aspirin is potentially effective in the prevention of preterm birth and stillbirth as well. Now, who should receive aspirin, when it should be started, and how it should be given? Who should receive aspirin? Women at high risk for preeclampsia. Most of the randomized trial recruited women with prior history of preeclampsia. However, as I presented earlier, there are several other factors that can be used to identify those women. As I presented earlier, the NICE guideline recommend that women should be identified according to several risk factors. But one thing is clear for now, it is that aspirin is not indicated in low-risk women, and it is not indicated for women undergoing IVF. So who should receive aspirin? Women at high risk for severe or preterm preeclampsia based on history or combination of factors. But we really need to find the best combination of factors, because treating women based on history only, it's like doing Down syndrome screening using maternal age only. It's not bad, but we can do much better. So when should we initiate the treatment? Between 8 and 16 weeks, according to the randomized trials available so far. I believe it would make more sense, and since in those studies most of the women were recruited between 8 and 12 weeks, I would recommend to start aspirin between 8 and 12 weeks. There is no study to demonstrate any benefits of starting low-dose aspirin before 8 weeks. And again, it makes sense since transformation of uterine spiral arteries start around 8 to 9 weeks. So how should we give it? In the morning, in the evening? Which dosage should we use? According to the very nice studies of Dr. Hermida from Spain, when aspirin is taken at bedtime, it has a much better effect on the mean systolic pressure and diastolic pressure than when it is taken in the morning. And combining his studies, his randomized studies, he found that when aspirin was taken at bedtime, there was a better decrease in the rate of preeclampsia and IUGR than when it was taken in the morning. So when we should recommend women to take it? At bedtime. Which dosage do we recommend? Our meta-analysis did not show a significant difference between aspirin taken between 80 milligrams or less and 80 milligrams or more. However, there is a concept that we should all need be aware of. Is the concept of aspirin resistance. Dumont and colleagues reported in an observational study that, and this was more than 10 years ago, that when aspirin was initiated before 17 weeks, it has greater benefits in the prevention of preeclampsia. Moreover, they found that when the bleeding time of pregnant women taking aspirin was greater than 2 minutes, the effect on the prevention of preeclampsia was better as well. Caro and colleagues reported that approximately 1/3 of the pregnant women are resistant to 80 milligrams of aspirin. And more importantly, women who are resistant to aspirin are more likely to have adverse pregnancy outcomes. Fortunately, it seems that we could adjust the dosage of aspirin using bleeding time or other platelet aggregation tests, such as the PFA 100. And by adjusting the dosage, you can still have a decrease in the rate of preeclampsia and severe preeclampsia in those women who are resistant to aspirin. So what dosage should we use? We have 3 options. You can give 75 to 100 milligrams daily to all women. You can give the same dosage and perform aspirin resistance evaluation, depending what you have available in your lab. Or you can give a greater dose, up to 160 milligrams, to all women, and there's no need for evaluation. I don't have the answer between what is the best right now. So the future studies include studies evaluating the optimal dosage of aspirin. Right now, there's a RCT in my center where we're going to compare 80 to 160 milligram of aspirin, and fortunately, the result will be available next year. There's a study, there's a need for an RCT recruiting nulliparous women at high risk, identified at high risk of preeclampsia, most likely with a calculator such as the one provided by the FMF. And there's also a need for a study that would compare low-dose aspirin to low molecular weight heparin in women with prior PE. Because there's 2 randomized trials that have recently been published. And the 2 trials added from the one from Dr. Ray, published 3 years ago, demonstrated that aspirin plus low molecular weight heparin was superior in the prevention of the severe cases of placenta-mediated complication, including severe preeclampsia, IUGR, and stillbirth, compared to aspirin alone in very high-risk women. So in conclusion, low-dose aspirin is effective in the prevention of preeclampsia and IUGR when started between 8 and 16 weeks of gestation in high-risk women. Low-dose aspirin should be considered in nulliparous women identified at high risk using multifactorial risk estimation, but a randomized trial is required. And the optimal dosage could be considered using evaluation of aspirin resistance. And finally, low-dose and aspirin and low molecular weight heparin in combination should be considered in women with previous very severe or early PE. In our province, now we recommend a combination of low-dose aspirin and low molecular weight heparin in women with a prior preeclampsia before 32 weeks, as a preventive, as a prophylactic measure. So I would like to thank all of my colleagues that helped me in this work, and you can find most of the data in those publications. Thank you very much.